Good morning.
సార్ స్టార్ట్ చేస్తున్నాం సార్. సార్ వస్తున్నారండి, సెట్ కరి పేపరు. लिखना
Sir, unit on page here. 2 gives.
नहीं हमारा केसेस कुछ लगा है
अपन करे सो रेगुलर डिस्कशन करें ना.
जो भी एक्सरसाइज नहीं लगा है
Some of these people are fixed with KYC. Some of the cases are Mandela fracture dislocation. There also is a open fracture, open Mandela fracture dislocation.
Just one. Oxygen versus fixation.
Just this case, this is very important.
Fixation of the radial, a comparative study of the functional outcomes of the two techniques. Conducted at the Department of Orthopedic Surgeon, Justice JS Charitable Hospital, Bangalore, and published on 2017. Coming to anatomy of the elbow joint. Elbow joint is a compound joint. It is made up of 3 joints. Radiocapital joint. It is a pivot joint. Allow pronation and supination. Ulnar-trochlear joint. It is a hinge joint. It allows flexion and extension. And superior radial ulnar joint. It is a pivot joint. It allows pronation and supination. Elbow stabilizers are static stabilizers, joint capsule, lateral collateral ligament complex, and medial collateral ligament complex. Dynamic stabilizers are biceps, triceps, and brachialis. Lateral collateral ligament complex, primary varus, and posterior lateral rotational stabilizers. First is annular ligament, second radio collateral ligament, and lateral ulnar collateral ligament. Now, medial collateral ligament complex, anterior bundle, key valgus stabilizer of the elbow, arises from anterior inferior aspect of the medial epicondyle to insert on the subline tubercle of the proximal ulna, and posterior bundle provides a secondary resistance to valgus load.
No, go back. Read karo. Subhana. Transverse part also is there. Then is oblique cord and annular ligament. Humerus, radius, ulna. And also you got a coronoid process. All are important. Yes.
Introduction. Radial fracture, the most common fracture of the elbow. Incident. Yes, sir. Sir, circumference.
Basic anatomy. Basic anatomy is
Common in women than men, and age group 20 and 60 years, and undisplaced and minimally displaced radial head fractures typically occur at isolated injuries, while more displaced and comminuted fracture commonly have associated injuries to the collateral ligament and may have associated fractures of the coronoid, capitulum, and proximal ulna. In high energy trauma, dislocation of the elbow and the forearm can occur.
so this is important. This is important. Sometimes the capsule is there. Capitular capsule, they come into the fragments. That you have to reduce. Only by fixing, you cannot get it. Sometimes you have to open the fracture and see the fracture fragments. Classification, Mason classification, 2-part, 3-part, or fracture dislocation. Whatever the capsule indwelling is there, you have to empty that. Then only you can plan for the fixation. On table judgment, yes sir.
Mechanism of injury of radial head fracture. Most radial head fracture occur at the result of low energy mechanisms such as fall on outstretched hand. Mechanism of fracture include three common patterns. Valgus load causes impaction of the radial head into the capitulum, commonly with rupture of medial collateral ligament. Posterolateral rotatory subluxation of the radial head with respect to the capitulum cause partial articular fracture of the anterior portion of the radial head with rupture of lateral collateral ligament. And axial forearm load cause impaction of the radial head into capitulum with more severe trauma producing fracture of the coronoid or rupture of the interosseous membrane and distal radioulnar joint ligament, so called Essex lopresti injury.
What is SS lopresti
Sir,
injury? It is a fracture dislocation.
sir, fracture with the interosseous membrane rupture will be there.
What fracture? What fracture? What dislocation?
Fracture of the coronoid and
Fracture of the coronoid. SS lopresti. Fracture dislocation.
dislocation, sir. Elbow dislocation with no. Sign and symptoms of the radial head fracture: pain, swelling, stiffness of the elbow and forearm. Ecchymosis may develop several days later, and tenderness over the lateral epicondyle may indicate presence of the associated lateral collateral ligament injury, while similar tenderness over medial epicondyle suggests medial collateral ligament disruption. This alignment of the elbow is assigned to rule out associated dislocation like Montezia and Gallagher.
You have to put the image of the SS lopresti fracture. There is a fracture of the distal end of the radius with the distal radio-ulnar joint disruption, with the interosseous membrane rupture, with the dislocation of the radial head. Migration. Yes, sir? అది కూడా దట్ ఈస్ ఆల్ సివియర్ టైప్, దాంట్లో కూడా ఇస్తాడు అది. దాంతోపాటు మైగ్రేషన్, ప్రాక్సిమల్ మైగ్రేషన్, disruption of the distal radio-ulnar joint, disruption of the distal radio-ulnar joint with interosseous rupture with dislocation.
Sir, in elbow, sir. Proximal, laterally. Lateral side. Laterally, sir. Lateral side of the. No, sir. Specific in.
Anconeous spot. Is there lateral epicondyle head of the radius in between? You are getting some spots. Anconeous spot. Yes, sir.
Range of motion, loss of forearm rotation is one of the primary indications for surgical intervention in setting of displaced fracture. A loss of terminal extension is expected as a consequence of the hemarthrosis which accompanies all radial head fracture. The distal radioulnar joint should be palpated and balloted for both tenderness and instability. Coming to classification of radial head fracture, Mason classification. Type 1, there is a marginal sector fracture without displacement, and in type 2, marginal sector fracture with displacement, and type 3, comminuted fracture involving the whole head, and in type 4, any radial head fracture associated with elbow dislocation.
What is this type 2 important? It is impaction. It is impaction and split, and also there is angulation. Anything can occur type 2. It is important. So these are the type 2 injuries. Type 2 and type 3, there may be soft tissue interposition, that is capitular interposition is there. These two are very, very important. Type 1 is undisplaced. Yes, sir.
Imaging and other diagnostic studies for radial head. Sir? Head. Imaging and other diagnostic studies for radial head fracture. Anterior-posterior and lateral radiographs are typically sufficient to diagnose most displaced radial head fracture, and undisplaced fracture may initially difficult to diagnose, and they may only be suspected for presence of anterior and posterior fat pad sign from the comminuted hemarthros. Sir, in undisplaced concomitant hemarthros. CT can be helpful for better characterize the size, location and displacement of radial head fracture. It is also useful to assess concomitant injuries of the coronoid capital and to look for presence of associated osteochondral fragments. MRI may useful to define the presence of associated collateral ligament injuries.
So what is the importance of CT? Osteochondral ligaments fragment.
To see the presence of associated
2 fragment, 3 fragment, 4 fragments.
Yes.
Comminution, you said comminuted. So when to fix, when to sacrifice, when to replace. All are important. All are important. Yes, sir.
management options: conservative management, Mason type 1 or minimally displaced less than 2 mm, type 2, and in operative management will do Mason type 2 more than 2 mm displaced, type 3 and type 4. Radial head excision, arthroscopically or open approach, open reduction internal fixation of radial head with Harvard screw fixation, and open reduction internal fixation of radial head with periarticular locking plate, mini fragment plate, and radial head arthroplasty. Radial head fracture, if undisplaced, will go for early motion. If displaced, no block to motion, will do early motion, and if block to motion, crepitus or concomitant injury requiring treatment. If a small unrepairable fragment excision will be done, and if repairable fragments, open reduction internal fixation, and if large unrepairable fragments, ligaments intact, will do radial head excision, and ligament ruptured, will do radial head arthroplasty. Sir. Coming to aim, to compare the outcome of elbow function between radial head excision and open reduction internal fixation of the radial head with mini screw of Mason type 2 and type 3 radial head fracture, to assess the complication that occurs in both technique.
So all your studies are closed fractures.
Closed
not
fracture.
Yes, sir.
And fresh.
Fresh fracture. Yes, sir.
Study design is a prospective study. Study time June 2013 to October 2015. Impact factor, a total of 40 patients between age group 30 to 50 years with Mason type 2 and type 3 fresh closed radial head fracture were included in this study. A total 50% of the patients were males and 50 were females. 18 patients, 45% presented with type 2 Mason radial head fracture, and remaining 22 patients, 55% presented with type 3 fractures. A first group of 20 patients who underwent radial head excision, and a second group of 20 patients who underwent open reduction and internal fixation with mini screws. Inclusion criteria: patient age group 30 to 50 years of both sexes, and patient with closed Mason type 2 radial head fracture, and patient with closed Mason type 3 radial head fracture. Exclusion criteria: Mason type 1 and type 4 fracture, patient with associated elbow dislocation and ligament injury, skeletally immature patient, pathological fractures, patient with associated ipsilateral upper limb injuries, head injuries and solid organ injury, patient with systemic complaints like diabetes, hypertension, and patient with associated osteoarthritis of the elbow and neurovascular injury. Operative techniques: the patient was positioned in supine with on the fluoroscopic table with elbow in 90-degree flexion, and internal rotation of the arm and mid pronation of elbow under general anesthesia or regional block. Surgical exposure for both the techniques employed as Kocher's approach to the radial head, the interval between extensor carpi ulnaris and anconis muscle. Here, sir, incision is we'll make longitudinal incision based proximally to the on the lateral humeral epicondyle, and the interval between extensor carpi ulnaris and anconus distally proximally, and these two muscles these two muscles are merged. Uh, Detach the superior origin of the anconus from the lateral epicondyle and separate the anconus and extensor carpi ulnaris. Pronation of the forearm moves the posterior interosseous nerve medially away from the operative field. Sir? In pronation, sir. Sir, PN will move medially, sir, while doing in.
Pin.
Sir? Incise the joint capsule longitudinally to exposure the capitulum and radial head. After exposure, the comminuted fragments were removed, and using a osteotome, the radial head was osteotomized and removed for the patient in excision group, and in open reduction and internal fixation group. The fracture fragments were reduced and destabilized with reduction clamps and fixed with mini screws. Above elbow slab was applied post-operatively and was maintained for 3 weeks. Suture removal and discharge was done on post-operatively 10 days. Here is the image, sir, in intraoperative image showing exposure of the radial head using the Kocher's approach with extension from right elbow, and in this image it's showing exposure of the radial head using Kocher's approach and fixation with mini screws.
Mini screws are there, mini plates are there. Headed,
Yes.
headless. It can be equitrack or it can be herpers.
Where are screws there?
Here,
Which part of head screws there?
sir, laterals.
Why not bottom?
Sir,
Which is the safe zone I am asking.
safe zone, sir. 105 degree 105 degree arc to the lateral of the radius head, 65 degree anteriorly and 45 degree posterior to the midpoint of the radial heads.
Safe zone is non-articular zone. Non-articular
in
zone
safe
of
zone
the
there is
arc
no
of the
attachment of
yes, yes.
muscles and
Posterior, lateral, posterior. The diagram is there. You had put the rockwood green.
tendons. Posterior lateral, sir, there will be no attachment of ligaments and muscles.
What else?
Sir,
You open the joint, you want to know which is the articular part. It's not articular part. But seeing the shape of the head and the surface of the head, the color of the head, can you make out this is articular, this is not articular? Articular part, surface is bluish and thick. Non-articular part is red and lateral side is thin. So you should make out that. That is lateral side is 60 degrees of lateral. You get this part which is safe zone. Then you put the screw, that's what you should make out which is articular part. One thing is, if the cartilage is thick and bluish color, always say articular part. Don't disturb it. Non-articular part is thin and pinkish. Then is the question. That's what it is. Safe zone is that.
yes, sir.
Right. This safe zone what you're talking is, now if this is what complete head. Now the outer side which is there, you can also make out which is pinkish and thin.
Yes.
Compared to complete head which is articular part which is there, which is thick and bluish color. That is normal cartilage. This side there is not normal cartilage, this is only thin one. With that you can make out this is the area which can safely put the screws or cable, whatever it is. That is the idea you have to expose always. This somewhere, I don't know where it is. This is what outer side should be. This is called the safe zone where you can make out clinically on the table. That's what you should know.
Yes.
So you have to do in the full pronation or supination or neutral.
Neutral.
You know you want to do it in neutral.
You only said no.
Sir, in neutral position,
Or if you pronate forearm, no, now the bones aggregate. Safe zone is there. If you supinate, it goes backward. With one inner operating feet. To avoid that always pronate the forearm so that
What is the purpose of the safe zone determination? Why do we need to put the screws in the safe zone?
Sir, to not to harm the attachment of the ligament and muscles, and
It will not come in the way, safe, that's what.
Now the radial head articulates with the sigmoid notch of the ulna, which forms the superior radio-ulnar joint. So in the arc of motion of pronation and
supination, pronation.
that particular sector is very crucial. If you put it too anteriorly, it will not allow pronation.
Yes.
If you put it too posteriorly, it will prevent terminal degrees of separation. So that arc, the diagrams they have been, the line diagram is there, showing the arc.
Only seen the journal, that's all. Didn't refer to get all, just journal is that, bring it out. There are so many things to learn in that.
Review had done at week 3, 6 and 24 weeks, sir. Slab removal and rehabilitation of the elbow was started on week 3. Range of motion and elbow function was assessed and scored as per the disabilities of the arm, shoulder and hand dash score system during all the reviews. The results were tabulated, compared and analyzed statistically using chi-square test, and the p-value is less than 0.05 was considered significant.
How long you followed the cases?
24 weeks.
24 weeks means 6 months.
6 months.
Short term.
What are the results you know,
Sir,
sir?
all fractures united at week 6, and at 6 months the dash score was noted to 14.23 plus minus 5.60 point for the excision group and 4.80 plus minus 2.73 point for the open deduction and internal fixation group with significant p-value less than 0.05. Sir. Here is the post-op 6-week x-ray, sir. Anterior, posterior and lateral radiograph for the right elbow at 6 week after radial head excision, and here after this mini screw fixation, sir.
After radial head excision, you have to stabilize the elbow joint for 6 weeks. Why?
6 weeks.
6 weeks.
Again.
It's not 6 weeks. Go back. Image. 6 weeks is
Too long.
No, sir, 3 week.
3 weeks maximum we can.
3 weeks, sir. After 3 week, that slab
Remove.
removes. Complication between
You have to stabilize the elbow joint for 6 weeks. Why?
not 6 weeks, sir.
Follow-up is different. Follow-up is different. Immobilization is different.
3 weeks, sir. Make it
Sir, 3 weeks, sir. Elbow slab applied.
right.
3 weeks.
That is what? Physiomobilization to prevent the joint stiffness.
Complications.
Really should be caretaker for 6 weeks. You will get a fibrosing. Otherwise, again you are going to get a proximal
Still.
migration. With the proximal migration, there is going to develop again distal radio-ulnar joint disruption. That is also one of the problem of excision of the radial head.
Complication in first group radial head excision, sir. Osteoarthritis 2, periarticular ossification 6, whereas in radial head fixation 0, and no complications in 9, and in radial head fixation 19. Total number of patient 20 in radial head excision, and in radial head fixation 20. Table showing the complication rate in group 1 and group 2. Complication rate were more in group 1 as compared to group 2. Limitation of the study, the sample size, sir,
The exercise,
fix,
is better. What you're saying is better, right?
sir. In fixation complication,
Type 3 fractures, type 3, it's not easy to fix multiple fragments.
All fractures or some fractures?
type 2 and type 3, sir. We are
Again, 4 more.
type 4 arthroplasty. only type 2 and type 3.
Type 4 is a terrible trade-off elbow.
Yes.
That will not standard one.
Treatment is entirely different.
In radial excision group, osteoarthritis is higher than the fixation group. That's what.
Yes, sir. In excision there is a osteoarthritis is more.
No,
How can that happen?
excision depends on the time. So doing between 2 weeks, nothing happens. Now beyond 3 weeks, the chance of getting osteoporosis is there. That is reason is there. So timing is important, surgery is important, approach is important here. Approach for excision is proper is enough. You want to fix it, you can do through lateral anatomy. That's the big difference is there. Approach is different for excision, for fixation. Excision only small is enough to get. You want to fix it, then length one. That is through lateral you can do. That difference is there.
What is ideal time for excision after the injury? Ideal time, is it immediate or you have to wait for some time? What time is ideal?
Within a week, if you do so, nothing happens. Otherwise, you cross about 10, 15 days. The chance of any situation is more. If I decide
Within
to do it,
weeks.
Should not,
keep it in mind.
should not delay it.
Yeah.
Otherwise joint becomes stiff. And it should not be done immediately next day also. Should settle down
Yes.
at least for 1 week so that the intraosseous membrane and the distal radial ulnar joint will settle down.
Any discussion part?
Sir. No, sir. Conclusion.
Previous teaching was you have to wait for 2 weeks
Right,
till the
right.
intraosseous membrane and the distal radial ulnar
Yeah,
joint
same
settle.
thing. After 3-4 weeks of doing it, you definitely have
Not 3-4
problem.
weeks.
Listen,
2 weeks.
immediately within a week you should do. Nothing happens.
2 weeks.
Cross even that, but then no problem.
Limitation.
What we discuss? Discussion part.
This discussion part, this open reduction internal fixation with mini screws or plate, that
190.
that is good, and that complication is less as compared to excision of the radial head.
Proper incompetent.
Sir.
This general. Not a standard one to discuss anything.
Discussion means they will compare it with
Yeah,
already
all-
established studies. No?
This-
What is the
this-
established literature? You've just given the results. Results is p-value
That-
significant.
What they have done in Bangalore, they are given it. That's otherwise they are not compared to anything else. Such a big topic to be discussed. Within one article, you can't decide what to do. In 20 patients, you can't say what is this. 20, huh? Anyway, this. Yeah.
Previous cases with radial head excision.
Yes.
When very recently, last week I got one patient who had radial head excision 25 years back.
Yeah, yeah. It's good. Yes.
Absolutely normal complete.
We,
No pain, no anything.
sir, we used to do same thing during 70s and 80s, sir. The movement, etc. We used to do it. Of late, we are fixing it. Fixing it has a lot of problem. Yes. If you do not know to fix, don't fix it. Just exercise it. If you know how to fix it perfectly, do it. With physiotherapy, and at least the protocol should be maintained. Otherwise, lot of problem for this.
Con-
Yeah.
Is more common in excision
Excision, right.
than internal fixation. That is more common with replacement. Head replacement.
And depends on how much you are exposing, sir. The approach you are giving more true lateral doesn't matter. And is only excision for the head is enough. If you want to fix it, no, let expose more proximally distally. So the chance of getting a MO is more here. Also can.
Actually, there is an indication for excision of the lateral marginal fragment,
Fragment.
which is in the non-articular area.
Yeah.
That is what you are mentioning.
Yes, yes.
Very small chip sometimes may get avulsed,
Yes.
not avulsed, fractured. When it is in the non-articular area, it is not a very significant
I can
size
forget.
of the fragment.
Yeah.
You can simply excise that and leave it.
That's what.
Then the humeroradial joint is intact, pronation and supination are good. Only excision of the small loose fragment.
That's enough.
Lateral margin, which is
No,
non-articular,
not.
almost lateral 1/3 of the sector
Right.
of the radial head is non-articular.
So what's the message in this? What do you want to do?
So that's open reduction internal fixation.
You don't want to find out what is the arc, which is articular part, non-articular part, how to diagnose it. All this is very important here. This is what you teach. 3 months old. This is the condition.
Metals.
So X-ray చేసిన తర్వాత
ఎందుకు ఎక్సైజ్ చేసినావు అదా
అది
ఓల్డ్ కదా ఓల్డ్ 4 months అయినా అది చేయదు ఇప్పుడు అది ఫిక్స్ చేయడానికి
With silicone, this
మౌంటిగే కదా
synovitis.
మౌంటిగే ఫిక్స్ చేయాల్సింది
Stiffness.
ట్రాన్స్ప్లాంటర్ పిన్ వేస్తే
Overstepping.
తర్వాత కావాలి తీసుకోవచ్చు
For this, they are using the computers, computer analysis to size the radial height. To size the radial height. It's also coming up.
Okay, right. You are not even mentioned one case done here. So many cases were done here. Fixation as well as excision. That would have been better. And the article is not that standard to be discussed here. Right. Okay, next.
So these are the case done under Unit 2. Chandu, 51-year male, 2-year-old post-op case of intertrochanteric fracture of the right femur with implant in situ. That PFN removal done. Nail removals, proximal femoral.
no, is it infected?
No sir, no infect. Yes. 2 years old. Sir, for now not working, sir, but
When they were working with
Up-
implant in situ was working or not? What was the gate?
implant in situ was working, sir. Up
Is it in virus or virus?
Algus.
What's the gate? Kept in the patient.
Yes,
What was the gate? You able to walk?
he's able to walk.
The link?
He's walking, sir.
No, I mean disturbance in the leg. Absolutely normal.
Absolutely no. Normal, sir.
You are not right. Only one case.
Yes. No admission. Last week, no admission.
PHR here.
Morning, sir. These are the cases done in Unit 3. It is 73-year-old male with closed supracondylar fracture of right femur with intra-articular extension. These are CT films. Here there is an intra-articular extension with metaphyseal comminution. This is a C2 type, 3-3 C2 type. We have way down open indentation internal fixation with a dual plating for right femur. Sir. Yes, sir. It prevents virus collapse. It helps in achieving articular congruency.
What was the approach they have got? Both sides.
Yes, sir. Sir? No, sir. Middle parapatellar approach. Middle. Only one approach.
What is important of swashbuckler approach in these cases?
It helps in we can approach both laterals and middle side with yes, sir.
J-shaped is the lateral approach, V-shaped or hockey-stick or J-shaped approach,
Yes, sir.
and swashbuckler anterior medial, anterior subgastric approach. What is the advantage shaped polycystic lateral arteries.
That's another.
Patient in supine position.
Yes, sir.
Patient is supine position. Yes. What is the advantage? You can see the intra-articular comminution, intra-articular anatomical reduction and articular congruity are better analyzed with swatch buckler approach
Yes.
compared to a standard J-shaped lateral approach.
Yes.
And the other important utilization is with the rotational deformation. When there is a rotational deformation.
No, sir, this is bone fragment. This is a bone fragment.
One fragment. Looks like
Yes, sir.
broken drill bit. Only one screw is there in the thoracic side.
Yes, sir.
Adequate.
No, sir. Spinal cord was, but its commission was there. We applied and
So it could not. So there is one more principle for how many length of how to assess the length of the plane. It is a transverse fracture, or it is a spiral fracture, or it is oblique fracture. If it is a transverse fracture, the length of the plate should be at least 8 to 10 times or 12 times lengthier than the fracture length.
Yes, sir.
Whereas transverse fracture 3 to 4 times. అది చెప్పాలి ప్రిన్సిపల్ ఉంది ఏవో ప్రిన్సిపల్.
sir, 3 times the length of the
3 times.
దేనికది
Oblique fracture three times.
3 to 4 times for communicated fracture, not for transverse fracture. Transverse fracture is different, spiral fracture is different, communicated fracture is different. All are not same.
Sir.
So in double ISO మీరు ఉన్నారు కదా సార్, they put a long plate. They said rigid construct prevents the loosening and infection. That is all the presentation.
So, next case, sir. 26-year male. Yes, sir. No, sir. We didn't immobilize it. So there is rigid fixation is there, sir. So, no. Yeah, articular congruency is assured.
one more screw.
Yes, sir. For 3 weeks, sir. 3 to 4 weeks.
Too long, the knee becomes stiff. Mobilize the knee joint.
Can we apply the cast plate?
Yes, sir.
What is cast plate?
Ebony cast, sir.
What is function of cast plate?
Okay.
You know, you have seen we applied cast plate.
No, sir.
That's a cast plate.
No, sir. Functional base.
Cast plate.
Functional base. It promotes knee movement. At the same, while immobilizing, at the same time, yes, yes, yes,
Know that.
yes, the functional base. It promotes along with the immobilization. It allows movements. So it prevents stiffness. 26-year male with a grade 2 compound middle third shaft fracture of right femur, sir. We have done a closer direction internal fixation with ILN for right femur and wound debridement.
Twenty 23 years male closed comminuted middle third shaft fracture of right femur, sir.
No, sir, it left open for a secondary surgery.
It is Wingwist Hansen type 4, sir. There is no cortical contact between the proximal fragment and distal fragment. It treated open reduction internal fixation with interlocking nail and 2 circulars wires, sir. Sir? Yes, sir. Camera.
Sir, good morning, sir. 35-year male with the closed trimalar fracture of left ankle, sir. This Lagenson classification, supination and external rotation. Yes. Yes.
Private facility, you have done it okay. And most RFS not paid by the patient. Huh? This
Posterior.
doesn't require a CT scan. You know very well the posterior fragment is clearly seen. There is no articular comminution. Only the malleoli. Posterior marginal fracture is seen, which is occupying about 20% only. CT is not mandatory for such cases.
Next.
RFC demo always, right?
Yes.
RFS. Pylon fractures requires CT scan. Pylon.
Yes. Sir.
It is not pylon. Is it pylon fracture?
No. Sir. No. Sir.
Final తెలుసుగా final fracture, right?
Kas. Sir.
Age ఎంత?
35 years. Sir.
35 ఉంటే final fractures or old people?
Old people. Sir.
That too, vertical compression force will cause pylon.
Yes.
Vertical
Intern.
fall from a height, landing on the heel.
Yes.
These are all rotational injuries. Rotational injuries do not cause pylon fractures. Okay.
Intra-articular. Yes. Complete articular.
Okay.
We have done open reduction internal fixation with plating for fibula and malleolar screw for medial malleus. Sir.
Syndesmosis involved in this case, not first slide, first one, before slide. Syndesmosis involved or not involved?
Not involved. Sir.
Subar classification.
Not involved.
Trans, supra.
Infra. Sir.
This infra, trans or supra.
Infra.
So syndesmosis
Not involved. Yes.
on table also you have seen examined
Yes.
clinically and radiologically corroborated.
Yes.
All is well. Very good.
So this is 74-year male with a 10 days old intertrochanteric fracture of the right femur. This comes under Boyden Griffith type 2. For this we have done CRIF with proximal femoral limb. And this is 59-year male with fractured neck of the left femur. This is a transcervical type and Gordon's type 2, sir. Looks like transcervical. And it comes under Gordon's type 2, sir. 59. Hip screw. DHS is full. And also lateral cortex is intact. So we have done cemented hip arthroplasty for the left hip, and so on both the horizontal and vertical offsets look perfect. Somewhat similar.
Sir. 50-year female with the closed distal third both bone fracture of left forearm. Sir.
You call it distal third?
Distal ends.
Distal end.
Distal ends.
Distal end. Okay. And describe the fracture.
Metafacial fracture or metatarsal with
With
the
ulnar styloid also.
segment classification here for both bones.
Yes. Yes. Fall. Sir. Slip and fall. Yes. 50 plus. Yes. Yes, sir. Associated ulnar fracture. We applied slab. Yes. Slab, sir.
Is
the
ulnar
no
styloid a
swelling.
fresh fracture or a old fracture? Ulnar styloid.
Fresh.
regulate definitely. But immobilize, you want to immobilize from affects or
Yes.
or just neutral.
Neutral.
Your diagram is there. The diagram is there, you can see, no? The lateral view or displacement normal, we now not much displaced, no?
Yes.
You can as well treat in neutral position only.
Neutral position.
But above elbow cast, not below elbow cast. Above elbow cast can be, then wait for about 2 weeks, not again displaced, we just leave it. That's what, yeah. But all need not to get surgery done, fixation with a plate or cave or everything.
You have done open reduction tunnel fixation with 5-hole LS plate for left radius and closed reduction internal fixation with K-wire fixation for ulnus.
Why fix ulna? Would have left it?
Sir?
You have left the ulna, what happens here? Ulna is not,
So now-
not length. But apply in the same way. But why 2 K-wires are applied for that? I will not. Was one not enough to put in there? How did you apply this K-wire, ulna? Did you go from the lower end
Lower ends.
Huh?
Yes.
to the medullary cavity into this?
Yes, sir.
But why again cross pinning you have done? But you can as well go from the styloid process below this. That's what the idea. You can directly get into the medullary cavity from below, not from above. That's enough to produce. Right.
So this is a 25-year-old male with a grade 2 compound proximal third shaft fracture, proximal third fracture of the right humerus. This comes under knee 4-part fracture, sir.
Is it open fracture?
Yes, sir, compound. Yes.
Where is the wound?
So we have sutured in the casualty.
Okay, where is the wound? Anterior posterior. It looks from anterior posterior.
Anterior lateral, sir.
Anterior.
Anteromedial.
Was it in connection with the fracture?
Yes, sir.
No. Well, this is displaced somewhere here. Now you are showing the more medially the suture, wound. Do you think it has connection with the fracture site there?
Yes, sir.
You have seen?
Yes,
You were there?
Yes, I was there. This is the 3D morphological CT, sir.
Again, CT.
Even
CT has become routine here. No?
articular surface is involved, sir, and even the greater tuberosity, lesser tuberosity, and humerus shaft. All the 4 parts were included, so we have done suspecting the
fracture?
articular surface of the humerus.
So what fracture is 4-part fracture?
4 part. Needs 4 parts.
But somewhere lower, upper 1/3 the fracture is there.
Mm.
Does it come in needs classification? No. Just shaft. Needs classification will not be applied here. So,
Yes, sir.
take the lateral side. Right down. Like split in it.
See on the axial where is the articular part? You see that?
Mm.
Looks to be split.
Head split is there.
Head split.
Is a different fragment. Neck is a different fragment. There is no
Yeah.
If not 3 parts, sir. If articular surface is not
You
intact,
say 4-part or 3-part is
so
split
4
there?
parts. Greater tuberosity, lesser tubercle, head and shaft. Sir,
Sir, no. That is fine.
with dislocation. No dislocation. Open fracture.
Okay. Open fracture
we-
is not connection to that.
We have done ORF with 6-hole Phillows plate for the right humerus, sir. And also for the shaft stabilization, we have done screwed interfragmentary screws.
But fixation is very good. Only thing you are unable to explain what the fracture is, where the fracture is, why you are doing it. Just you are learning this, putting K-wire or putting a plate. That's enough. Right.
Sir. Sir.
The little low should be. Low, right.
So 46-year male with intertrochanteric fracture of the left femur, sir. It is body and grip with type 2, sir. We have done CRF with PFN for the left femur. And this is a 60-year female with subtrochanteric fracture of the left femur, and she has a history of proximal femoral nailing for the right side 2 years back, sir. And this comes under Russell-Taylor classification type 1A, non-involvement of piriformis fossa.
Is it normal pattern fracture or something else? This is called atypical fractures, no?
Yes, sir.
What are the types you get? Bone density is there. Curvature
Porotic,
is
sir. It appears porotic.
No, it means people who have used these bisphosphonates, they have set it right. Also petrosis as well as these things. Yeah.
Sir.
And short oblique or transverse is the normal you can see in these atypical fractures.
Sir.
Where pathology is different. That's what atypical fracture is. Yeah. But the curvature and all depicts in the classical case.
Now this X-ray is showing increased density all over the pelvis.
Sir.
There are two conditions, common conditions. One is osteopetrosis, the other is the fluorosis. How do you distinguish between the two radiologically? Both are sclerosing conditions, both are sclerosing. Can you distinguish radiologically between the two conditions? Of course, fluorosis from endemic area, that is history. But radiologically, how to differentiate between the two? Radiologically. Don't you notice that there is a generalized increased density?
Yes, sir.
Huh?
Yes, sir.
No, it will be very much, it will be like chalky bones. Chalky bones. And in fluorosis, there will be prominence, irregular margins at the muscular or tendinous attachments.
Sure.
All the attachments, they will have a bony projections, irregular bony shadow at the attachment of the muscles or the tendons. That is the hallmark. And it looks like a chalky white in osteopetrosis, whereas in fluorosis, you find coarse trabeculae. You still find the trabeculae, but they are very, very dense. That is the main difference. And in fluorosis, in osteopetrosis, the bones look radiologically strong, but they are brittle. They produce banana fractures.
What other name for this condition? What are the other differential diagnosis? Any name is there? Osteopetrosis is there. Chalky bone. No name.
I don't know, sir. I don't remember, sir.
Ulnar stromal disease.
Tell, sir.
Example other is there. You know what other things? Not in
Sir.
In other differential have you gone for LDH, alkaline phosphatase, serum calcium, ionic calcium?
Sir.
And rarely it is possible that it can be due to multiple osteosclerotic secondaries, bone forming secondaries, like prostate and some bronchogenic carcinomas. There, and some are mixed secondaries. Some produce purely osteolytic secondaries. Some produce purely osteosclerotic secondaries. So that is the third differential diagnosis for generalized, especially around the pelvic area. The secondaries are very, very common. Pelvis. So these are the three differential diagnoses. One is osteopetrosis, second is fluorosis, and multiple secondaries.
Multiple secondaries.
And what is DISH? Diffuse idiopathic skeletal hyperostosis. And also in some of the cases of period disease. Why also mimic like this? So we have to count on alkaline phosphatase, LDH,
Serum calcium.
serum
Paget's disease, how it differs? Why can't it be Paget's disease? Because you did not say about Paget's.
It has both osteoblastic and plastic activity, bone resorption and bone forming. So
There will be deformity, but you have to, sometimes I think you have to, yeah, differential diagnosis.
yes, sir.
Any Paget's also. Paget's generally what happens is there will be deformity and may not be uniform. It's not affecting entire pelvis. Yeah. So
we
what
have
was diagnosis were done?
yes, sir.
What was it?
Actually, we haven't done the apart from radiological investigations. We haven't done the clinical, sir.
So how do you make a diagnosis?
We'll reconsider the clinical investigation, sir.
Diagnosis. Okay, you fixed it. Next X-ray. You fixed it.
Yes, sir.
So did you do anything when you fixing?
We have done open reduction, sir, and then stabilize the fracture, and then we have passed the long PFM.
Okay. What else did you do to help in the diagnosis?
Is there any difficulty in draining the medullary canal?
No difficulties, sir. We have easily passed through it.
Was excess bleeding?
No, sir.
Did you send biopsy? No, sir.
No, sir.
You should send biopsy.
Yes.
Do investigation. Could be. What else it could be?
Ideally speaking, you can take a small piece of iliac crest.
I think you opened it. You could have taken a little piece,
We could have.
medullary or whatever there. You should do. Because diagnosis also, of course, whatever may be the diagnosis, treatment is same, but you can have supplementary treatment if you find something different in diagnosis. Yeah. Do all the, yeah, go.
The X-ray exposure also makes a lot of difference. Normal X-ray,
No.
normal bones can be seen as osteosclerosis.
Yeah, of course. Yeah, quality of it. But the repeat X-ray also looks same, but maybe. See, the canal, medullary canal is not affected. There is no deformity of the femur. So, only increased sclerosis, nothing else apart from. Yeah, so maybe. Okay.
Osteitis deformans is also called as osteitis deformans is also called as Paget's.
Pages, there will be deformity. That's what I said. Okay, go on.
Sir, 45 years male with closed middle distal third junction shaft fracture of left tibia. Sir.
This also looks proximally, it's increased sclerosis. So, maybe the X-ray, the way they take an X-ray. Go on.
We have done closed reduction internal fixation with the ILN for left tibia. Sir.
Okay.
So this is a 35-year-old male with 2-year-old right tibial plateau fracture with implant in situ. So we have done implant removal for this case, sir. And we can also note the osteoarthritis.
So why did you take the plate out? Go back. What was the indication?
The patient himself came and asked for implant removal, sir. No complaints, sir. He's having osteoarthritis, but patient himself came with
They want it removed.
You want to remove, sir.
Okay. Maybe good for the patient because he would need a replacement. Makes the next operation easy. Okay.
Sure.
Yeah, go back. Yeah. How old is he?
30, 35, 33, sir.
He's still admitted?
He not yet discharged.
Not yet discharged. Okay. Bring him to the OPD. We'll convince him. Maybe he could have done osteotomy same time.
Sir.
There is get his long leg film. If any deformity, then we can correct.
Sure.
Okay.
So 33 years male with 3 months old malunited middle third shaft fracture of left clavicle, sir. Malunited, sir. Yes. Patient. Yes, sir. Deformity is there, sir. Yes.
Any symptoms?
No symptoms.
No symptom. You have to be very careful. Was there any functional disability? No.
No, sir.
How old is the patient?
33 years.
You explain to the patient. 33.
Yes, sir.
Yeah, probably that may be old fracture. Fracture of the inferior. Yeah.
At the time. Yes.
Yeah. And you have to be careful counseling the patient.
I done open reduction internal fixation with 8-hole plate for left clavicle.
Was it united completely?
Sir, yes.
Okay.
70 years female with 10 days old intertrochanter fracture of right femur.
Okay.
Then we have done close reduction internal fixation with proximal femoral nerve for right femur, sir.
Recently, there was a publication in from NHS. 50% of these short nails failed. So we had to be careful. We don't know how many united. There's nothing in the neck. Nothing in the neck. 60%. So probably for we may have to think about it and do study. Short nails complications very high. Probably we can do a study, follow all the cases. Yeah. And failure, implant failure, non-union, very high. That's why they are going back to DHS again. The complication rate of DHS is very low for these fractures. Okay, go on.
But the luring factor is minimally invasive, quick surgery.
This is 74-year female with intertrochanteric fracture of the right femur. This is in Boyden Griffith type 2, sir. So we have done CRF with proximal femoral nailing for the right femur.
Sir,
Go back. Always it's better to have good direction on medial side. Lesser trochanter is off. Where is the lesser trochanter? Yeah. So it's always better. People say, what is attached to lesser trochanter? What is attached to the lesser trochanter? Which muscle is attached? Tendon. Huh? Anybody? Ilius is big muscle. So people say, but not people say, it's I think evidence to fix that one. Little pass wire around it, minimal incision, they have better results. Because muscular balance is not maintained, so non-union or failure rate is high. Okay.
Sir, 14-year female with the cavernous deformity of left foot. The residual deformity is there. Equinocaverous.
Where is the clinical picture? No, right, okay. First,
Sir, congenital, sir. Actual bilateral, sir. Right side treated 10 years ago, sir.
so is a post CTV.
Sir, no, sir.
Ah.
As in first bilateral is there, sir. Right side treated surgically 10 years back.
10 years
They
back
did not
means when she was 4.
Yes, sir.
So what was the diagnosis?
Congenital CTVs. CTVs.
So CTV, it was CTV, okay. Okay. So how much is the deformity? What are the findings you see?
This
Gate, you should expose a knee and then, you know.
it's a painless, sir.
fact that there is a big callosity on the left
Yes.
Mm.
is an indication that she is walking on the left.
Lat-
Okay. This is your examination case? Examination case here. Okay.
How far the deformity was correctable? Passively.
Yes.
Any deformity you should see whether it's a fixed
Fixed.
or correctable or partially correctable. Then only you will have an idea of the treatment. Okay. So what was done?
We have done osteotomy, sir, cuboidal osteotomy, lateral closed wedge osteotomy for cuboid, and fusion with 2 K wires, sir. Calcaneocuboid fusion is done, sir.
Right.
Then medial, posterior medial soft tissue release also done, sir.
Hmm.
This stainless release done. Yes, sir.
Okay.
This is tender Achilles lengthening also done, sir.
Right. Deformity correction at the end of the procedure. Where is it?
This.
So it is short of triple fusion. You didn't do triple fusion. Oh. Okay.
Any minimally invasive procedure?
Stainless done. Yes.
Without opening the
We can try external fixator.
Yes.
No, Elizaro, yes. But a triple fusion would have been better? Oh. All right. Right, okay. Okay. You should show the clinical picture, important deformity correction. Not post-op. Okay. Post-op. Next time present that one.
Okay, sir.
Okay, good.
Sir, this is a case for discussion, sir.
Hmm.
The-
Go back. What did you first no.
Actually, 52-year male came with complaining of pain, sir, for two weeks back
Right.
in right thigh. We have done X-ray and advised MRI also, sir.
Hmm.
But patient not willing for MRI. Taken pain medication and went off, sir. After 2 weeks, he came with follow-up.
Hmm.
When came here, he fall down, sir. This fracture shaft is done.
You fell down and came, fell down.
Came
and fell.
at
Came
in
and fell down in the
entrance,
hospital.
at
huh?
entrance.
He have a follow-up and then fell down.
Right, okay. Good for him. At least he will not refuse anything now. So what's the diagnosis? Go back to previous X-ray. Describe the X-ray.
The cystic lesion is
Cystic. Is it cystic lesion?
lytic lesion.
Yeah, lytic lesion, okay. So what happened? Describe all the findings. Well defined or ill defined, how far,
Well defined.
what happened to the medulla, what happened to the cortex?
Well,
Hmm? It's not well defined, yeah. Right? Multiple lesions or single lesion?
there is also lesions.
Just looking at the X-ray, what do you suspect? What is the commonest bone malignancy?
Bone sisters.
Bone cyst. Not studying, yes, I think. Cyst is a benign. What is the commonest bone malignancy?
Second.
Anybody?
Secondary.
Secondary deposits. That's the commonest one. Do you think it could be secondary? Has he had any surgeries, any treatment in the past?
No.
No, sir.
No. Secondary could be secondary deposit. Most likely maybe secondary. Or what else? What is a primary bone tumor that can happen like this? Spreads with the blood. Lesions in the skull. Primary bone tumor. Multiple myeloma. Okay. Next one. What is the most important part in management of any malignancy or a tumor?
Origin of primary source of.
What is the key for management, treatment? If you want to get the best treatment, what do you want to know?
Biopsy.
Diagnosis. Diagnosis is very, very important. So, in a tumor, how do you diagnose? What are the things? Just a biopsy or anything else? Not red tumors. Anything's classification or diagnosis? You have to know clinical, radiological, and histological. Then only you can diagnose, you can grade, and you can plan the treatment. Okay? What was done?
Case for
Or discussion. Okay. So MRI scan done.
MRI suggests to benign lytic lesions.
Simple cyst. They have not seen a simple cyst. I think that's why they have.
55.
Can't be simple cyst. You must go and tell them. Okay.
No, sir.
No.
What is skeletal survey? Not reading at all. Not reading at all. Anybody? Skeletal survey. For a tumors, you do skeletal survey. You do 3 X-rays. What are 3 X-rays? Or 3, maybe more than that. What X-rays you do for skeletal survey?
Skull, spine,
Skull X-ray, spine X-ray,
pelvis.
pelvis, chest and extremities. With, of course, modern thing, you can do a PET CT, PET scan, but skeletal survey still holds good. Done, not done. In this type of this X-ray skull is important to rule out. What investigations were done?
Just MRI.
That's it. X-ray then MRI, because you're not doing anything. Just send for the patient. So next to Thursday, one of you present management of bone tumors. Seminar on management of bone tumors. Okay. And what bone tumors we treated? We treated Dr. Anjaneyulu, Dr. Jagadish treated. Collect those cases and present them.
Why did they say that it is a benign discussions? There is no soft tissue swelling.
No.
There is no peritumoral edema. These are the two important.
Yeah. So soft tissue and but if in a secondary deposits may not be. Multiple myeloma there may not be. Yeah. Okay. Yeah. So what management? What do you do? Do skeletal survey. Do biochemical markers and do a biopsy. What kind of biopsy you do? Not reading at all. When you put a case, you should read, at least if not read in the past, you should read about it and come. There is no point in just presenting X-rays. What kind of biopsies? Anybody? Nobody is studying. Lakshmikant and Jai Krishna, you're not teaching them. What type of biopsies are there? MBBS question.
Open, sir.
So you can have a needle biopsy. Needle can be fine needle aspiration biopsy, which is not done in orthopedics, or a true cut biopsy. You get a piece of bone. Then open biopsy. Open biopsy, what types are there? You can do excision biopsy or incisional biopsy. To read about. In bone tumors, I think one of you should, next week only bone tumors. Okay. So do biochemical, admit under whom, which unit? First unit, okay. Criteria, yeah. Classification as well. Okay, done? That's interesting. So you should come with next week. What is the, go to the radiologist and discuss with him as well. Unless you discuss with them, you won't be knowing. They will know. They won't know, you won't know. Not really.
యాక్చువల్లీ హెడ్ టు టూ అంటే మనం కూడా చెప్తాం సార్, కాకపోతే ఆడు చెప్తే కాదు అంటే ఎట్ అయిపోద్ది అని.
ఎక్కువ కాన్సన్ట్రేషన్ చేయాల్సింది, అంత కెమెరాస్ మీద కాన్సన్ట్రేషన్ చేసి దీని మీద ఎక్కువ రండి.